for many years we've used a smear. That's Mycobacterium tuberculosis, sputum put onto a slide and then used to identify Mycobacterium tuberculosis. That's a robust, simple tool and has served us well for over 100 years. But it doesn't serve us well in the days when we need to understand drug resistance in a quick and efficient way.
The importance of diagnostics in the current era is that we want to be able to make a diagnosis promptly. We've got better and better about that. The introduction of molecular diagnostics, such as GeneXpert, have undoubtedly improved the sensitivity and also the speed of diagnosis. What's most interesting about areas such as that is that you need both a very good test, which in general terms can be used close to the patient, so a point of care test, but also you need to re-educate your healthcare workforce and individuals who are being tested, the implications of the test and the value of it. One of the big questions about treating tuberculosis is that because the mycobacteria is both a slow-growing organism and also because it's relatively hardy to being killed by antimicrobials, it takes a long time to treat and effectively cure TB. So, for example, the standard therapy to deal with latent tuberculosis is 3 months of treatment continuously. The standard treatment for drug-sensitive active tuberculosis is 6 months of treatment. These are drugs that have potential toxicities. That in itself is a problem because, again, if someone is feeling more unwell on the therapy, then there's a good chance they may stop treatment.
Unfortunately, we haven't seen any improvements in the treatment of TB really for 30 or 40 years. And whilst those are very effective trials and the regimen works very well in trial settings, as we've seen in the history of the tuberculosis epidemic, the regimen is inadequate to control the disease. So we do need new treatments. We need better treatments. We need safer treatments, shorter treatments, treatments that are easier for patients to take. There's been a number of trials published in the last 2 years looking at 4-month treatments, the idea being that a shorter 4-month regimen would be easier to take for patients, and if it could be shown to be as good as the current standard of care, then that would greatly improve outcomes in practice and make it easier for tuberculosis programs to roll out treatment for a larger number of patients. Unfortunately, those 3 large trials showed that none of the 4-month regimens that were being evaluated were as good as the standard of care. So we're still looking for shorter treatments that can result in better outcomes for tuberculosis. A lot of the work in trials at the moment is looking at how we can best identify the most promising regimens to take forward to large, expensive trials. And so some of the work that we've done, some of the research that's being presented in the BMC Medicine journal series is looking at better ways of doing clinical trials to identify those regimens to take forward to large phase 3 trials.